Good afternoon and welcome. I'm Sumanth Swaminathan, co-founder and director of Vironix Health. Vironix is a digital health company that leverages advanced machine learning algorithms and cloud API technologies to remotely detect, monitor, and triage infectious viral illnesses. We're a group of passionate scientists, clinicians, and entrepreneurs dedicated to utilizing AI technologies to diminish and eradicate deadly global illnesses like COVID-19. We have with us today Anna Berryman and James Morrill. Anna is a second-year Ph.D. student at Oxford University, working on the modeling of the labor markets through the post-carbon transition. Anna studied her undergraduate degree at the University of Bristol, finding the areas of statistics, probability, and data analysis particularly interesting. Anna recently completed an ML algorithm development project under the supervision of Dr. Terry Lyons and James Morrill at Oxford University, and Dr. Sumanth Swaminathan at Vironix Health. He or she developed prediction models for identification of severe presentations of influenza. Welcome, Anna. James is a final year PhD student at Oxford University's Department of Mathematics, working on machine learning methods and time series analysis with a focus on medical data. His undergraduate and master's programs were both at Oxford, where he focused primarily on applied mathematics. He's worked on a range of projects under the advisement of Dr. Terry Lyons, Dr. Sam Howison, and Dr. Swaminathan, including prediction of congestive heart failure from at-home patient data, monitoring of stress levels from physiological signal data, and early detection of sepsis from ICU data. Welcome, James.
Hi, Swami. Nice to be here.
Great to have you both here, guys. And I just want to start by giving you an opportunity, just in your own words, maybe just tell us a bit about how your education experience at Oxford has gone, and maybe the origins of your early interest in applied mathematics. Shall we start with Anna?
Yes, thank you. So while I was doing my undergraduate degree at the University of Bristol, over the 4 years, it became clear that I was more interested in applied mathematics, and the chance at Oxford University to work with industrial partners meant that the maths that I was doing in my PhD would have a real impact in real life, and I think that's really clear working with Vironix, that our work is going to have an impact. So that was really a driving force for me for continuing my maths research.
Wonderful. And James?
Yeah, so similar story here. Enjoyed maths as a high school student, and then did undergraduate degree, which had both pure and applied sides, but focused more on the applied mathematics into later years, just because that's what I found an interest in. And at the end of my 4 years, I knew I wanted to continue research in mathematics, but I didn't know specifically what area. And so I went onto a PhD course where the first year was specialist skills, and it had a focus on industrial partnerships with industry and doing projects related to industry. And then at the end of the year, after you've seen a number of different things in the field, you partner up with a company and do a project proposed by that company. And so this gives you, first of all, a chance to see different array of things and then choose after the end of that year. And you can also do things in collaboration with this company, which means that you get to see real impact of the research, and it keeps it focused on things that are immediately useful, which is very nice.
Great. And in that spirit, for our folks watching, both James and Anna have actually done, very pivotal work, as it relates to the mission of Vironix, particularly in doing at-home diagnostic and triage work in viral and chronic illnesses. And so, Anna, can you just tell us maybe a bit more specifically about the project work that you did with Vironix, and specifically what kind of problem were you trying to solve, and what types of methods and techniques did you leverage in solving that problem?
Mm-hmm. Yeah, so the original project was aiming to apply machine learning techniques to triage influenza patients to determine whether they'll have a severe or non-severe presentation of flu. And in order to apply the machine learning techniques, we needed to create some patient profiles on which we could train our machine learning models. And so we ended up developing 3 different methods for creating the patient profiles based upon research that was available in the literature, and they differed in how they treated the relationships between the different characteristics of the patients. And then once we realized that we could either treat the patient characteristics as completely independent, or we could apply a rejection method, or we could use a new mathematical object called a copula in order to incorporate some of the relationships we had between the different characteristics going forward. And once we had these 3 different data sets, we were then able to apply our machine learning techniques in order to investigate whether, first of all, we have the ability to predict whether the patients will have a severe or non-severe presentation of flu, which we rather successfully did. And then on the other hand, we were interested in determining which of the 3 methods was the most representative of real patients. And interestingly, more work will be needed to be done, because at this stage it doesn't look like the 3 methods have that many differences, and so it was really interesting to see that we could feed back on what Vironix had did with their COVID paper and apply a sort of peer review in a sense, where we looked at their methods and also provided a new method.
Right, and that peer review ended up being invaluable to us, right? Because as you pointed out, one of those 3 methods that you were using is something that we were doing with our COVID-19 work. And a lot of what we were hoping to do was establish the rigor of those methods, that particular method, as compared to some of the other options. And what your project did was actually bring some light, shed some light on other ways to convert this clinical characteristic data into patient scenarios for training algorithms. And that was really an invaluable piece of work for us. So congratulations to you on that work. James, you focused more in your independent work with us on a heart failure problem. Can you tell us a bit about what you were trying to solve there, and what types of methodologies and techniques that you leveraged, brought to bear when solving that problem?
Yeah, so this is similar work in the sense that it's aiming to provide at-home diagnostic information to patients who are in an at-home environment. And this is done through app and physiological signal data that's easily obtainable by a patient when they're situated at home. And in particular for conditions, for chronic conditions, so people who have to live with these things for the whole of their lives. And these conditions, with these conditions, patients exhibit what's known as flare-ups or exacerbation events, when they have relatively fast changes in their symptoms that can cause very problematic events, and they generally will need to seek medical care. And it's about how do we give patients more accurate information as to whether or not they are experiencing a flare-up, given information that we can take at home. And so it involved a lot of machine learning, in the sense that we gathered data from some of the most important characteristics for predicting these flare-ups for given conditions, and building models on this information to be able to put this in an app that a patient can use at home, and they can triage themselves as to what they should do, whether or not they should stay at home, they should call a doctor, or they should go to the emergency room, depending on the severity of their symptoms. And the thing that's particularly interesting about this is very difficult to gather information like this with accurate labels, because it's difficult to know whether or not someone actually is experiencing exacerbation. It's quite rare. You have to track a lot of people for a lot of time. And so the way that this was alleviated is to get characteristic patient profiles, and to have a wide range of doctors and physicians to label these cases to what they would do if they saw this this patient come into their office. And then we train models using that information that a doctor had provided, and therefore the models are able to mimic the response of a doctor. But more than that, we were able to use multiple doctors, and so aggregate the information from the opinions of lots of doctors into one model. And then we can test this model against each of these individual doctors' predictions on a validation set that was not used in training. And you can actually show that the model will predict more accurately on the consensus opinion of doctors than any individual doctors. And therefore, it's not only taking in information to predict as accurately as any one doctor, but as a consensus opinion of doctors, and therefore one could see it as safer and more reliable than any individual triage from a given doctor using the same information.
Which is a pretty profound result, right? Because what you're showing is that an algorithm that's taking a set of perfectly available data at home is effectively more accurately assessing critical flare-ups of illness than trained cardiologists and triage assistants, triage nurses, etc., who do this, obviously in their own professions. One interesting distinction between your project and Anna's, right, was that you were using physician opinion data, as you mentioned, to train your algorithms, right? And Anna's project was using what's often considered more objective data, right? So this is just data that's been gathered from clinical studies on the characteristics of people who have severe, non-severe presentations of illness. James, you worked on both projects actually, because you were supervising Anna's project as well. Did you see, and I know this is not an easy question to answer, but did you find anything particularly interesting or challenging in handling the data between those two projects? What that means in analyzing them, making rigorous conclusions, et cetera, et cetera.
Yeah, so I mean, that's a very good question. So one thing that I thought was particularly distinct between the two projects is that the first one I worked on with the doctor labeled data is it was a more standard supervised machine learning problem in the sense that we have doctor labeled data, we have a validation set with multiple opinions from multiple doctors that we want to test against. We want to build models and test against this validation set. And so we have a very well-defined metric in this sense. And then it becomes quite a standard machine learning project of we have these symptoms and physiological signal data, such as heart rate, blood pressure, and all this sort of stuff from a training set of patients. We build a model and we test it against this and we know what performs well. Whereas the difference with the project that I worked on with Anna for Vironix is that the less work has been done in this field where we have this clinical characteristic, tables of clinical characteristics because the data cannot be shared. And so in a table write-up of thousands and thousands of patients with influenza, they give you these statistics data about who had a severe case or a non-severe case of influenza. And so deciding on how we can validate this procedure and how the pipeline is going to look is more complicated because this is less of a standard supervised machine learning problem where we know what metrics are important and how all this stuff works because people have done it 1,000 times. And we had to really think about the pipeline. And if we set up a pipeline of building a model from this data, first of all, will it look to us as scientists, the model at the end, how can we build this pipeline and validate it such that to us, this seems a sensible and convincing thing to do, and also to patients and clinicians, how can we design this such that it gives us a result at the end that we can be satisfied with and users will be satisfied with. So there's a big difference there, I feel, and there was kind of a more high level thinking required with the project with Anna that was quite interesting.
Mm-hmm, mm-hmm. And some of these validation barriers you just pointed out are so critical in actually deploying these products because obviously we want people to use them and be safe, and we want the clinical community to validate and establish that they're rigorous predictions. And on that subject, Anna, I'm sure it might have surprised you when you were doing your work as well, right? That this started maybe as a traditional machine learning project, but you probably spent most of your horsepower and most of your time in handling the data, right? And so can you talk a little bit about, what did you find to be most challenging when you were executing your project? Was it really more on the data handling and transforming end and getting that to work right, or on the machine learning end? And what do you think was probably the most critical finding of your work?
Mm-hmm. Yes, definitely. I think when we started out, we thought it was going to be much more of a machine learning project, and it did end up being more of my time dedicated to actually getting the data really thoroughly generated in a way that we could back up with different mathematical ideas and go forward in a way in which we were all happy that the patients that we were then training the machine learning algorithms on were actually realistic of patients in real life. And I think going into the project, it was going to be really exciting that I was applying the machine learning techniques that I'd learned through my studies into a real situation. And I think actually what happened was really representative of real life, because as James was saying, machine learning has had a lot of research into it. And I think a lot of the manpower in these sorts of projects is in the data collection and making sure that all the data is there before you then start your machine learning or whatever predictions you're going on to do. So I think it turned out to be really representative of a real project, and that definitely gave me challenges in different places that I wasn't expecting, but it was really fun to work through the things which came up, which were sort of unpredictable and unexpected.
Right, right. And it was obviously a pleasure for us to work with you, obviously, as well. And just to, this is a classic lesson for all the people who do machine learning in the healthcare space too, which is that data acquisition, cleaning is often and transformations is often where a lot of the work happens because of the nature of the healthcare data landscape. For the two of you, maybe you can tell me just a little bit. You were co-supervised, obviously, by Vironix and Oxford, and you have very different talent sets over there. I mean, of course, as your advisor here, I do have a mathematics background, but, I've been in the entrepreneurial space for quite some time. Maybe just briefly, can you tell me what it was like to work between the two places? Did you find certain strengths in one place versus the other? And did you find that it was a good working arrangement? Because Oxford is obviously doing this program with other industrial institutions. I mean, how did you feel about the program itself? Anna, why don't we start with you?
Yes, I think it's definitely valuable to have the two perspectives from the math side and then also the application, and the different inputs are really valuable when we're starting out with the projects. And I think especially here, because the maths and the sort of health sector knowledge were so sort of different from one another, it was really important that we had, I had two specialists who could advise on the two different sections. And I think it really complemented each other well, because the two perspectives were able to give different opinions on one another's ideas, and that then meant that we were more critical in a way of how to move forward, but that then meant that we really nailed in where we needed to go with different questions, because we knew from the math side what we were trying to answer, and also from the healthcare side what we were trying to answer. So we didn't sort of veer too far away from what we were really trying to do, because we had both of those perspectives helping all the way through the project.
Which makes for an amazing collaboration, right? When those perspectives are so critical. James, what do you think?
Yeah, I mean, I'd just echo that. The key aspect, the reason why our PhD program was set up is because there's not enough connection between applied mathematics, academics, and industry. And of course, doing applied mathematics, you want it to be applicable, and especially in healthcare domain, there's a lot of constraints as to how the end product can actually be applied, because it's being deployed with real world patients, and the outcomes can obviously range massively, and it's very important to get that right. And so having the connection between the mathematics department and Vironix has been great. The mathematics department you get all these ideas into new and wonderful things that are going on in machine learning, but Vironix, the interaction with Vironix helps you stay grounded into regions where what you'll do will actually be applicable at the end, which is obviously what everyone wants. And it was appreciated from the Vironix side that this is still a PhD project and it needs to be licensed to have freedom of research, whilst giving us all the tips and information needed to have something that will actually be useful at the end of it. So yeah, I mean, I would say it's been great.
Wonderful, wonderful. I don't want to put you both on the spot, but I'd love to know what your aspirations are, maybe ambitions over the next few years as you, perhaps move on to other things? I know, Anna, you're early in your education at Oxford, but James, do you think you can provide some high-level points?
I can give it a go. So, I mean, the thing I've enjoyed most is doing what I guess you could call cutting-edge research into problems that have immediate application, and the application really helps guide where the research goes, and I find that really helpful. And I also find that that really helps motivate me in what I'm doing. And so, what I'd like to do in future is stay in the medical technology domain, whilst doing things that are mathematically interesting and interesting in machine learning and computational context, whilst learning everything there is to learn about the medical side, and how everything kind of fits into place and joining the two regions together. So I guess the ideal for me is a small team startup doing some interesting medical technology projects, just like Vironix, I suppose.
We love to hear that. We love to hear that. And Anna, you could talk maybe a little bit more about some of the methods or directions of research. Obviously, you have probably 3 years still left in your program, or is that right?
Mm-hmm. Yes, yeah, 3 years left.
So, over the next few years, where do you think you'll be spending a lot of your mind space and time?
Mm-hmm. Yeah, so I think the reason that I'm really enjoying the program that I'm doing is that we're able to make real impact with our work. And so the Vironix project that we did really emphasizes this. And my research project is looking at how the labour markets will be affected by the post-carbon transition. And so a lot of the data cleaning and analysis that I learned while I was with Vironix will be really applicable because when I'm trying to calibrate my model of the labour markets, all of the data that we have available to us, it will be quite a task to prepare it all. And I think that will be something really valuable that I take from my work with Vironix into my research over the next 3 years.